Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Stroke remains the third most common cause of death in the United States. Is sleep apnea a risk factor? Do strokes cause sleep apnea? To explore these important relationships and their practical significance, my guest today is Dr. Melissa Lipford, a board-certified neurologist and sleep specialist at Mayo Clinic in Rochester, Minnesota. Melissa, welcome. The relationship between sleep apnea and stroke is complex and probably bidirectional. Let's start with discussing pre-existing obstructive sleep apnea as a risk factor for cerebrovascular disease. There have been several studies, and I believe the consensus is that OSA is an independent risk factor for both men and women. Have I got this right? Is this correct? Is it only severe sleep apnea, or are all grades of sleep apnea involved in increasing risk?
Great. Well, thank you, Mike. It's a pleasure to join your podcast today. You're correct. Several studies have implicated OSA as a contributor to stroke risk, and among those, the Sleep Heart Health Study, which was published in 2010, is the first study, in my mind at least, to demonstrate that OSA is an independent risk factor for stroke. In this study, they did baseline polysomnography studies on close to 4,500 people without prior stroke history or history of significant cardiovascular disease. And then the study followed them for over 10 years. And none of these patients were treated for sleep apnea during the study. And then after they adjusted for age and various cardiovascular and cerebrovascular comorbidities, they found that men with moderate to severe OSA, so an AHI of over 19, had a threefold increased risk of stroke compared to those without OSA. There was a similar relationship in women, but at a higher AHI threshold. And then to further the evidence, there was a nice meta-analysis involving 16 studies and over 24,000 patients that demonstrated that severe OSA is associated with a doubling of stroke risk. And so, based on current data, it does appear that having moderate and severe OSA are associated with increased risk of stroke.
Well, that seems very robust data, and I don't think it's fully recognized by many physicians. So a few years ago, you published an important study looking at which mechanism of cerebral infarction correlates best with OSA. You found that most patients with OSA who did suffer a stroke had cardioembolic infarcts rather than infarcts due to primary large vessel atheroma or small vessel hypertensive disease, the three main mechanisms of cerebral infarcts. So, what are the possible mechanisms involved here in this relationship between emboli from the heart into the brain and sleep apnea? And how should this affect our clinical practice?
Well, you're right. At Mayo Clinic, we looked at mechanism of stroke in patients with OSA compared to those without OSA. So we took patients who had undergone in-lab polysomnography at our facility and then suffered their first ischemic stroke within a year of the sleep study. And then we used the PSG results to divide those patients up into those with and without sleep apnea. And then in a blinded fashion, we looked at the subtype or mechanism of stroke in each of those patients. And we used a standard classification system that takes into account different clinical features, neuroimaging data, cardiac data, and laboratory tests. And we found that in the OSA group, cardioembolic strokes were much more common. 72% of the patients with OSA had suffered cardioembolic strokes, and that compares to only 33% having cardioembolic strokes in our control group, those subjects without OSA. And when you talk about mechanism, just as a bit of background, the majority of cardioembolic strokes are due to atrial fibrillation. And when a clot from the heart embolizes, the brain is showered with infarcts of varying sizes. So these strokes can be devastating. They're severely disabling in about 60% of patients and result in death in 20% of patients. And from prior data, we've learned that OSA is strongly associated with atrial fibrillation. In fact, the heart health study that I referred to earlier showed that having moderate to severe OSA is associated with a fourfold risk of developing atrial fibrillation. And we found that the frequency of cardioembolic stroke increased as the severity of OSA increased. And that relationship held after we adjusted for multiple vascular risk factors, things like hypertension and things like that. And then what was interesting is that relationship continued to hold even after we adjusted for the presence of any known history of atrial fibrillation or atrial flutter. And so that suggests that potentially the OSA population has a higher rate of occult or undiagnosed paroxysmal atrial fibrillation that may be contributing behind the scenes to their stroke risk. And you asked about how might this impact clinical practice. Well, I think it has a role in cryptogenic strokes. So when someone presents after a stroke, our job is to figure out why that stroke happened and address those causative risk factors to try to prevent them from having another stroke. And we know that in general, cryptogenic strokes make up about 20 to 25% of all strokes, where we do a thorough evaluation, but we're not sure of what that underlying mechanism of the stroke was. And in these patients, our typical approach is we treat them with antiplatelet therapy and just general risk factor reduction strategies. But the data I just presented, it would appear that the strokes in patients with OSA tend to be cardioembolic in mechanism. So I might propose if you have a patient with known OSA who presents with a cryptogenic stroke, we might have a higher level of suspicion for an underlying cardioembolic mechanism. This might be a group of patients where we would push for doing long-term cardiac monitoring to identify occult paroxysmal atrial fibrillation that might escape detection otherwise. Because if you can find evidence of atrial fibrillation, that patient can be initiated on anticoagulation therapies, which then confer a 40 to 70% recurrent stroke risk reduction. Whereas if they were maintained on only antiplatelet therapy, they're only getting about a 20% reduction in stroke risk.
So let me be provocative. Should we take everybody with severe or moderate to severe OSA who hasn't had a stroke and investigate them for occult atrial fibrillation, or wouldn't that be cost effective?
Yeah, it's a great question. It's probably that cost effective because doing long-term cardiac monitoring is expensive. In some cases, you're using implantable devices. So I don't think we're there to that data where we would proactively do studies like that at this point.
Okay. Well, let's move on then to the opposite. The possibility that acute cerebral infarction may cause sleep apnea. Now, meta-analyses of multiple studies indicate that a huge number, at least 70% of patients following acute strokes may have sleep apnea, and some studies have shown as high as 90%. At least a third of these patients appear to have severe sleep apnea. To me, this suggests this extremely high frequency of sleep apnea after acute stroke. It suggests to me that the infarct itself may be causing the sleep apnea rather than it simply predisposing to sleep apnea. In other words, it wasn't there before and is there now. Is this correct? And if so, what might the mechanisms of how a stroke can cause sleep apnea, considering, as I understand it, there seems to be no correlation with the size or location of these infarcts, and most of the sleep apnea seems to be obstructive rather than what you might theoretically predict might be central sleep apnea, say after brainstem infarct. No, wherever it is, most of it's obstructive. So tell us about this.
Yeah, that's a great sort of chicken or the egg question. The current literature would suggest that there's a bidirectional relationship between OSA and stroke. So OSA contributes to stroke risk both as an independent risk factor as well as contributing to other cerebrovascular risk factors. We know that OSA can contribute to hypertension. We talked about atrial fibrillation, but just as you said, it also appears that strokes cause OSA. And you're right, the extremely high frequency of OSA that's observed in the aftermath of a stroke, that 70 to 90%, would suggest that at least in some cases, the stroke itself must have led to the development of OSA. And it appears that there are certain stroke characteristics that might be associated both with the development of OSA and that severity of OSA. Strokes in particular that cause facial or pharyngeal weakness will potentiate collapse of the upper airway. And I've certainly seen this on the hospital stroke service taking care of patients. You can have a patient who's rail thin, never snored a day in their life, but then after having a stroke, that has facial weakness associated with it, you can hear their snoring and apneic pauses out in the hallway. So I think that personally, I think the biggest factor that might lead to developing OSA as a consequence of a stroke is facial weakness. We definitely need more data here to look at those specific stroke characteristics that are more associated with OSA. Some of the data also suggests that brainstem infarcts and those that have had recurrent strokes are also at higher risk of developing OSA. But I do think the driver in many cases for OSA is facial weakness.
Well, that makes complete neuroanatomic sense, and it would also explain why so many infarcts in so many different locations might cause
Right.
it. Because if you have motor involvement anywhere from the cortex through the internal capsule, through the brainstem, it will have a sort of final common pathway of weakness of the face and the pharynx if it's unilateral, or sometimes obviously bilateral. So let's discuss management of the sleep apnea in the setting of acute stroke. You mentioned your work on a stroke service. Should every patient with an acute stroke have some sort of sleep study while still in hospital? Is there evidence that early treatment of this obstructed airway improves the prognosis from the cerebrovascular event? And if you do go that route, do these patients acutely tolerate CPAP therapy?
Those are great questions. And I have to say, I'm more likely biased towards early testing and treatment of sleep apnea and stroke patients. But from a practical perspective, in the acute stroke setting, especially when patients are still in the hospital, it can be logistically very challenging to coordinate sleep testing and implement treatments for sleep apnea. And so I would suggest reserving treating hospitalized patients in the acute stroke setting, it really in those who are more likely to have severe disease. We do have a little bit of background. The Joint Commission standards and the American Heart Association, American Stroke Association guidelines do recommend conducting continuous pulse oximetry monitoring after an acute stroke. And so going back and looking at the oximetry data might be a way to screen for those that are likely to have more severe OSA and consider further testing or potentially implementing treatment in the acute phase. Without severe disease, it may be better to wait just a little bit until at least after hospitalization. And then in terms of literature on whether treating OSA improves outcomes after stroke, the data is mixed, and we really need more evidence to guide us here. Some of the studies, both in the US and from colleagues in Spain, have shown that treating OSA in the acute stroke setting does lead to improvements in neurologic and functional recovery, as well as increasing the length of time from that incident stroke to the next stroke or cardiovascular event. But then there was the SAVE trial that came out in 2016. It was a large study. They took patients with moderate to severe OSA and one cardiovascular risk factor and randomized those to treatment with CPAP versus no treatment or kind of usual care, and followed them for about 4 years. And at the end, they didn't see differences in stroke incidence between the two groups. But I do want to point out that there were some significant limitations in this study. In particular, the mean adherence to therapy in the CPAP group was only about 3 hours a night. So essentially, they were comparing untreated patients to a group of minimally treated patients. Additionally, the study was never designed to address the essential question of what is the role of CPAP in secondary stroke prevention, which is what you asked, or stroke recovery. And we certainly need more work here. The Sleep Heart Health study is one of those pivotal studies that hopefully will start answering these questions. But what I can say that is backed by some of our literature from our colleagues in rehabilitation, as well as my own personal experience, is that after a stroke, these patients often have debilitating sleepiness, and that sleepiness greatly impacts their ability to participate with early rehab. And treating sleep apnea can impart improvements in that daytime sleepiness, their nocturnal sleep quality, and overall energy levels. And that can make it easier for them to participate in those important activities that really help towards stroke recovery. Um, and then I think finally you mentioned tolerance to CPAP in stroke patients. This is another really challenging topic. The few studies that have looked at this have shown pretty dismal adherence to CPAP in the stroke population. And I think this is because stroke patients have additional challenges beyond the general population in acclimating to PAP. Facial weakness that we talked about before and asymmetry, which probably contributed to their OSA to begin with, can make it very challenging to get a good interface seal. These patients typically require a full face mask, and drooling can be an issue, claustrophobia can be an issue, and so it definitely takes some time to find the right interface style for them that seals well and is comfortable. In patients with aphasia, where the stroke has impacted critical language pathways, it can be very challenging to educate these patients on how to use PAP therapy and address their discomforts. And then another huge factor is, especially in the acute setting, sleep apnea might be pretty low on that patient's priority list. When a patient has just suffered a major medical event, they're wondering, can I return to work? Can I return home? Do I need to move to a skilled environment? Am I going to be able to walk again? And so it's important to meet the patient where they are and not push with CPAP if it's not the right time, and potentially wait a little bit.
Very helpful insights. Just to clarify one point, the SAVE trial that you mentioned, that was a secondary prevention trial. These patients had all had cerebrovascular events?
So these are patients who did not have a stroke. They had had moderate to severe OSA plus a cardiovascular risk factor, and they followed them over time to look at incidence of stroke between the group treated with CPAP versus the untreated group.
Okay.
So
Okay.
yes, it was not designed to look at that role of CPAP in secondary stroke prevention.
Okay, so that's something which still needs to be
Correct.
looked at
Correct.
in understanding how important it is to start these patients. So as you say, it's very hard to start to study them in the acute setting. They don't tolerate treatment well. So should you rather wait, say, 6 months and restudy them then? But most studies, as I understand them, who followed patients with OSA following acute stroke, have found that the sleep apnea does persist at that point, that it isn't just a transient phenomenon, although severity might slightly decrease. Is this also correct? Is this your experience on studying them later, that it persists?
Correct. I have seen that it persists over time, and I think there is some work, and with strokes, we sometimes worry about central sleep apnea, but there was a
Mhm.
large meta-analysis that looked at this. Many of the studies didn't distinguish between central and obstructive disease, but in the few that have actually broken it down, the vast majority, over 70%, had mainly or all obstructive disease. So only about 7% had predominantly central apnea. And there has been some nice work from some of our colleagues that have looked at time course of sleep apnea following the stroke. And it shows that if there is some central sleep apnea, that tends to improve following the stroke event, but the OSA stays behind. In most of the patients that we've looked at here, as well as supported by some of the studies, the obstructive sleep apnea occurs either prior to, it's been there before the stroke, or maybe it's contributed to by the stroke, but it does tend to persist. I think it's more from a logistics standpoint that reason to wait. One is, just kind of getting the patient over the initial kind of shock and the issues that relate to having a stroke. It's important to give them a little bit more time, but probably within about 3 months is the right time frame to actually study them and actually get them on treatment, and potentially sooner if that oximetry data might suggest more severe disease, because then it really can impact their ability to participate in early rehab. And so that might be a time to actually consider earlier testing and implementation of treatment.
That's very important. So even though the very incomplete, and data doesn't necessarily show that you can prevent further strokes and things, but you certainly can help their symptoms.
Absolutely. And you know, CPAP is really a low to no risk intervention. And if it helps improve quality of life, it gives them better sleep quality, allows them to participate better in rehab. It's in my opinion, it's certainly worth testing and treating these patients.
So, Melissa, thank you so much for sharing your expertise with us. I don't think there are too many neurologists around with expertise in both stroke and sleep disordered breathing. Are there any final messages you'd like to leave with our listeners?
Well, Mike, thank you so much for having me today. I guess as some final points, I'd like to remind your listeners that OSA is an independent risk factor for stroke. As you pointed out, it's not often thought about, and in fact, we think only about 2% of stroke patients actually go on to have definitive testing performed. And so, it's important to recognize these relationships. It's also important to underscore that OSA is associated with increased risk of atrial fibrillation and may be associated with cardioembolic strokes. And the data I've presented today might suggest that we should consider long term cardiac monitoring in OSA patients who have presented with a cryptogenic stroke. We also talked about the need for more data to assess the role of CPAP in secondary stroke prevention and stroke recovery. And as we talked about, you know, even without a full set of data here, we're talking about a really low to no risk intervention that can help these patients. And even though they do have challenges in implementing CPAP, if you take a flexible approach and really work with these patients, often we can get to the point where they are successful with CPAP. But we should also look at potential CPAP alternatives if if PAP isn't a realistic option.
Well, thank you so much.
Thank you, Mike. Appreciate your time today.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.